Okay, good morning, everybody. My name is Connor Collins, and I'm going to be presenting on refining your health history intake with respect to managing concussions. We're going to talk a little bit about the pathophysiology of concussions to start, and then we are going to get into some red flags. Sorry, just one sec. Get into discussing red flags. So first off, everybody make sure that they go and grab Richard's book. It's an amazing resource that he's put together, the ebook that he referenced at the end of his presentation. And thanks to Mark and Amanda for having me. They're really pushing the field of massage therapy ahead, which I think is what we're all trying to do here. And just having this event is a really great milestone for the field of massage therapy. So who am I? So I am a massage therapist and a sports injury therapist. I practice 45 minutes outside of Toronto, Ontario in Canada. And the majority of my practice now is more so concussion focused, about 30 to 40% of it's concussion focused. And I first started in practice teaching and treating a lot of triathletes. And what I discovered was, as my triathletes started to get contact injuries, I just wasn't very good at treating and managing them. So I started to delve into the world of concussion, took a lot of concussion courses, and have kind of morphed my practice into 30 to 40% in the management, treatment, and rehabilitation of concussions, which is where the majority of my focus now lies. Outside of treating, I'm also on faculty at Mohawk College in Hamilton, where I've been an instructor now for 6 years and been teaching in the industry for about 14. So I'm entering now into my 14th year of practice. And that's just a little bit of a quick background about myself. So before we start today, I think it's important to try and define a very ambiguous injury to all fields of manual therapy, which is looking at mild traumatic brain injury or a concussion and trying to define or give something a black and white definition that is often very gray. And to do this, it's probably the easiest to go to the mild traumatic brain injury guidelines. And so they define a concussion as an acute neurophysiological event relating to blunt impact or other mechanical energy applied to the head, neck, or body while with a transmission of force. And this can happen from a sudden acceleration, deceleration, or rotational force. And there are a variety of things that can cause a concussion. So the first thing that's important to know about a concussion is what a concussion is not. So a concussion is not bleeding within the brain. So when we have bleeding within the brain, it is an injury, but it's a more substantial injury. Concussion is not increased pressure within the skull. So if the skull is swelling, then obviously that is an injury as well, but that is not a concussion. A concussion is not a fracture to the cranium. A concussion is not a neurological event or a disorder. A concussion is not an infection or a virus. And a concussion is not a progressively worsening injury. And so why this is important is for a couple of reasons. Obviously, if you're seeing more substantial neurological declines in patients or people, then it warrants a referral immediately. And the other thing is that while it's important to understand what a concussion is, for the patient, it's also very important to understand what a concussion is not, because they get very apprehensive when they've had a brain injury. And the one thing that gives them a lot of calmness and peacefulness is when you tell them that their brain is not bleeding or swelling, because many people think that when they've had a concussion, there's some sort of swelling or bleeding that's gone on in the brain. So adding that element of reassurance can be really, really great for just allowing the patient to be calm during something that's very, very complex. So when we talk about the mechanisms of a concussion, and we talked about acceleration and deceleration forces, what that creates inside the brain is something known as a coup contra coup effect that you can see on the left of the slide here. So what happens to an acceleration deceleration injury in the brain is typically there's a whiplash that has occurred. And this might be from a direct hit to the head, but often, and more often than not, it's not actually coming from a direct hit to the head. And that's one of the common myths surrounding concussion, is that anytime you create whiplash, you're giving yourself the opportunity to get a concussion. So this can be from a car accident where you don't directly hit the head. This can be from a slip and fall where you hit your bum on the ice while ice skating, or you can actually get a direct blow to the head. And what that causes is first a coup injury. So the front of the brain or the side of the brain, depending upon whether or not it's rotational or straight on, will hit the skull, and then it will bounce off of the skull on the opposite side. And with respect to concussion injuries, rotational movements of the head seems to be a little bit more substantial than getting hit front straight on. So if my head's going in this direction, front and back, for those of you that can see me, if you are rotating through the head, because the base of the skull is has a little bit more peaks and valleys because of the cranial nerves, rotational movements of the head may in fact, or there's thought that they may in fact cause more substantial concussion injuries than being hit head on. The other common myth is that you have to lose consciousness to have had a concussion. So if you lose consciousness, you've surely had a concussion or worse. But if you don't lose consciousness, you can still have suffered a concussion. So I'll say that again. If you've lost consciousness, you've surely had a concussion, bare minimum. There may be also a more substantial brain injury that's gone on. But if you do not lose consciousness, it does not mean that you have not suffered a concussion. So two big things there. You don't have to hit your head. You don't have to lose consciousness. Now, when we look at the signs and symptoms of concussion, there are many. This is again taken from the guidelines from Mild Traumatic Brain Injury 3rd edition. And so if we just look at a few here, signs and symptoms, any period or loss or decrease in level of consciousness that's less than 30 minutes, any lack of memory for events immediately before or after the injury. This is known as post-traumatic amnesia, and this can last up to 24 hours in a mild traumatic brain injury. And then any alteration mental state at the time of injury, which is usually characterized as confusion or disorientation. And then there can be a host of physical symptoms, which we'll discuss, I believe, in the next slide, including vestibular symptoms, headache, weakness, etc. Also, note that, and we'll talk about this in a few slides, is when should people look at getting imaging, whether that be an X-ray or a MRI or CT scan following a head injury, and what are the guidelines showing for that. So when we look at now the pathophysiology of concussion, and we want to just discuss a concussion in overview, there are really three things that go on. There is an increase in energy demand within the brain. There is a decrease in energy supply within the brain. And there is an alteration in blood flow within the brain. I'll say that again. So there is an increase in the demand of the brain's energy because of the injury. There is a decrease in the energy supply to the brain, also because of the injury. And there is a decrease in blood flow to certain areas of the brain, most notably the areas that were injured after the brain injury. If we look at an acute concussion, so this being a concussion that is a single event, so we're not talking about a patient that has suffered 3 or 4 concussions inside of a year. Let's just, for the sake of argument, say that this person's never had a concussion. So we're looking at something known as the acute neurometabolic cascade here. And this has been studied at length by a number of people, but this was first found by Christopher Giza in 2004. And then he's updated his neurometabolic cascade in 2014. And the study is referenced below in the slide here. And I'll provide the slides to you, or I'll give you a means to get the slides at the end of the presentation. So in this slide in blue, we have 2 axons or nerve cells within the brain. And we have in green, we've got our ATP pump here, our sodium potassium pump that's powered by ATP. So we have a mechanism of injury. Let's say we've been hit to the head and we temporarily lose consciousness. This creates a mechanical change in the brain. It might create a little bit of a stretch in the axon, a little bit of a compression in the axon. And this is happening, again, at a very microscopic level. Bear in mind, in a concussion, you're not going to have any MRI or CT findings. If you have those, that would indicate that the brain has been injured in a more substantial way. So we have this very small physical thing that happens to the axon. And when that happens, in between axons, we have neurotransmitters, and neurotransmitters are responsible for talking from one axon to another. They are essentially the wire to the telephone. And the particular neurotransmitter in the brain that's used to be a messenger is glutamate. So when you get this physical injury, glutamate release is altered in between the axons. And sometimes it will spike, and then other times it will become low. And this changes how the axons in that area will communicate. Now, at the same time, we have a whole bunch of potassium that leaves the cell. And in response to that, we have a whole bunch of calcium, and we have a whole bunch of sodium that goes into the cell. Now, if you think back to physiology sort of 101, when we're talking about action potentials, inside a cell, generally we have a negative charge. And when calcium and sodium rush into the cell, we have a positive charge. And that's what elicits an action potential, which is this all or none event. And so when you have potassium leaving the cell and calcium and sodium rushing in, you're getting this action potential over and over and over. So the nerve cells go into overdrive. And what the sodium potassium pump does is it says the brain's really, really active right now. So what I need to do is I need to use that sodium and potassium pump to try and regulate the balance in between the cell. And the sodium potassium pump is reliant on a couple of things, or the leaving of sodium, or the regulation rather of balance, is reliant on a couple of things, sorry. The first is the sodium potassium pump and how well it can work. And the second is how well the mitochondria within the cell can work. And the mitochondria, if you remember, are essentially the engines of the cell. Now, the brain relies on sugar as its energy source. And so what happens is we start to go through hyperglycolysis. We start to create a lot of sugar because we want to get sugar inside the cell. So the brain's starting to adapt. It has a lot of sugar, but it can't get it inside the axon to reestablish its balance. And the reason it can't get the sugar inside the axon is because of that decrease in blood flow to the area. So we've got sugar available, but we don't have blood to help distribute it properly amongst the nerve cell. And as a result of that, we have high energy demand. The brain needs a lot of energy, but can't get the available energy into the axon to re-regulate itself. Now, after probably 24 to 72 hours of trying this, the brain goes into a really suppressive state. It sort of gives up for a time being, and it goes into this really hypoglycolytic state where it stops producing sugar. And why this is important is this state in most research lasts for about 7 to 10 days. And this is the time where someone is most vulnerable to a subsequent injury, in particular, a subsequent concussion. And what we know is that if you get a second or third concussion within this 7 to 10 day time frame, then there's further potential for complications and longer prognosis for healing. And this is why you see a lot of protocols being, when in doubt, sit the player out, not returning players or patients to their activities on the same day that they've been injured, and certainly not within the first 7 to 10 days. And it has to do with this acute neurometabolic cascade. Basically, the axon goes into haywire. The sodium-potassium pump tries to regulate things along with the mitochondria, and it can't do that because of a lack of sugar, or not, sorry, a lack of blood flow around the injured area. Now, a concussion is different than if you've had, let's say, a number of concussions, say 5, 10 concussions over a short period of time or over a lifespan, or you've received a number of what are called subconcussive blows. So let's take a look at now what happens if we go into a more chronic injury. Now, this is, again, been investigated by Giza, and this is known as a chronic neurometabolic cascade. And so this is when you get repeated brain trauma over time. This would now not really be considered a concussion, but those that are familiar with or have heard the term CTE, or chronic traumatic encephalopathy, I'll say that again, CTE, chronic traumatic encephalopathy, which is where a lot of research lies in sports like football, rugby, and investigating players after they've retired. This is what we're talking about when we talk about CTE. So again, we've got our axons here. We have our altered neurotransmitter release still going on. And what we now have is we have long-term mitochondrial dysfunction. The mitochondria, because of repetitive brain injury, continue to suffer and can't regulate the cell. There are two additional things that happen in chronic states. And one is we start to get chronic inflammation outside of the axon. And the other is we start to get abnormal protein accumulation inside the brain, or rather inside the axon. And that protein is known as tau protein, TAU. And tau protein is already inside of all of our axons. That's sort of it provides architecture to the tubule inside the nerve. So it's kind of like scaffolding. And what happens in chronic brain injuries is the tau starts to break down. And what that will do is cause the neuron or the axon to basically atrophy. So in chronic brain injury states, we start to get apoptosis or cell death as a result of that. Now, this leads to a whole host of potential problems, including psychological or psychiatric disorders, things like chronic anxiety, depression, early onset of Alzheimer's or perceived Alzheimer's. And the problem with the chronic states of brain injury is we don't have any way of diagnosing them until post-mortem autopsy. So we can't see these brains until after death. And there does seem to be a difference in a brain-injured brain versus somebody that has like an Alzheimer's or dementia. And the main difference being is the lack of something called a beta amyloid plaque in brain-injured individuals versus somebody with Alzheimer's. Now, the thought with more chronic states of injury was that this was something that you would suffer from when you were older. Maybe around 45, 55, you start to see early onset dementia. But if any of you have watched the Netflix documentary on Aaron Hernandez, the former Patriots football player that ended his life, they believe that CTE may have played a role in the cause of death, not necessarily the complete cause of death, but he was 27 when he passed. And so there is some thought now of CTE developing in younger patients as early as their early 20s if they've had either many brain injuries within a short period of time, as well as they are investigating subconcussive blows in sport, which means blows to the head that don't cause a concussion, but there are many of them that happen over the course of a few years. This is one of the reasons why the NFL has taken hitting out of football practices a lot of time and monitored football volume for players. So what happens now in terms of the symptoms? So when you are starting to see a patient in your clinic, what symptoms are you looking for in a post-concussive patient versus a maybe regular patient that's suffering from headaches? And when you look at the symptoms of post-concussion or a concussion, they really fall into three boxes. So the first box is the physical box. We can get headache, nausea, vomiting, blurred or double vision, visual spots, issues with balance, dizziness, and sensitivity to light or sound, also known as photophobia or phonophobia. We can also get ringing in the ears and vertigo. Now, as you see, these are also symptoms of many other things. So it really does take a very thorough assessment to try and determine whether somebody has suffered a concussion in conjunction with usually the medical doctor that's overseeing the case. When you look at the behavioral aspect, there may be things like drowsiness, lethargy, fatigue, irritability, anxiety, depression, sleeping more than usual, or difficulty falling asleep. There's also the cognitive aspect, which is feeling slowed down, feeling in a fog or dazed, difficulty concentrating, and difficulty remembering. Now, the memory piece is really, really important because many people will say that they have, following a concussion, they've lost their memory or they have lost the ability to essentially harvest their short-term memory. And what that is a lot of the time is they haven't lost their memory. The brain is very inattentive. And because the brain has so much going on around it, people just lose the ability to concentrate. So if I take my pen and I put it down on the desk and then somebody talks to me and I'm going, and then I have to grab my keys, I've lost my concentration. I've been inattentive because of all of the inability for me to the inability to discriminate my surroundings. But I perceive that as losing my memory. It's not overly common to lose your memory in concussion. It is much more common to lose your concentration or your inattentiveness. Again, maybe a speaking point to patients because patients will become very apprehensive about that particular symptom that they feel. When we look at the prognosis of symptoms in concussion, we want to look at a time frame. So if we look at, say, 0 to 4 weeks, we have a patient that comes in between 0 to 4 weeks. In that 0 to 4 week period, they're still considered as having a concussion. So the research used to say 7 to 10 days. There's newer research that's pushed this out a little bit. And the reason, again, that this is important is there are a lot of people that won't resolve their symptoms in 7 to 10 days and get quite apprehensive about it. And usually when people are still within that first 30-day period, I'm saying as long as you're progressing, you're still within that acute period, and this is perfectly normal. Now, as the person gets pushed from 1 month to the 3-month period, so 1 to 3 months, they are considered to have post-concussion syndrome. And this is still without any improvement. So their symptoms stagnate and there's no further improvement. They would move into the post-concussive syndrome state. Lastly is if the patient is now pushed beyond the 3-month period, they fall into what used to be called post-concussive syndrome. We now refer to it as persistent post-concussive symptoms. One of the things that we know is the longer that this goes on, the more complicated it gets, and that's merely by virtue of time. And the longer the time, the more elements get layered on to any injury at all. So from a psychosocial perspective, maybe the person's off work and that has detrimental effects. So the longer that things are going on, the more complex it's becoming. So where I want to go next is I just want to now talk a little bit about how you would structure a health history and what questions you would ask, as well as very small exams that you can add to your intake that I think are quite helpful. So from a questions to ask standpoint, firstly, how many concussions have you had? Ideally, when you hear somebody having had 3 concussions inside of a year or more, that's not a great thing. There seems to be a magic number about 3. And in particular, what was the time frame in between each concussion? Ideally, the longer the better. The shorter the time period, the more potential there is for complications. What was their approximate age at the time of each concussion? Why this is important is there's a thought around, or there was initial thought around children being more resilient to concussions because they're generally more resilient to a number of injuries. So for example, if a child breaks their arm, it heals quite quickly. What we now understand is that concussions in children should be taken more seriously because the brain is developing, and they typically do need quite a bit more time to heal properly before being returned to school or their activities of daily living. So I consider, again, a child for the purpose of concussion, definitely under the age of 16 or younger, but can be between 16 and 18 as well. Bear in mind that there are aspects of the brain that won't fully develop until the age of 22 to 24 in certain people as well. The next question, did you report the concussion immediately? Reason being is you want to know whether they had maybe a subsequent blow to the head, especially if it is within that first 7 to 10 days. And if they have had prior concussions, you want to know how long did it take them to recover from those, and if the recovery has gotten progressively drawn out. And what methods did they use to recover? Did they use chiropractic? Did they use massage therapy? Were they doing rehab? As well, are there any similarities to their concussions? So was headache a prominent symptom for them? And were they a headache sufferer prior? And the one question that is important that is not a great answer, if the answer is yes, is each concussion getting progressively worse and taking longer for you to recover from? For the simple fact that, again, this makes things a little bit more complicated from an entire healthcare team and perspective managing the injury. So now let's move on to talking about red flag screening in these patients. So important things to ask your patients when they're coming in, and important things to look for, as well as important exams that you can do. So I break this up into 3 areas: the vertebral artery and the upper cervical spine. So this is looking at whether there's something more sinister going on, like a red flag, an injury to the vertebral artery. Let's say they were in a high velocity car accident, or a fracture to the upper cervical spine. Then break it down into the cardiovascular system. And then lastly is a section called other. So first, with respect to the vertebral artery, and I know that and especially when we're in school, the vertebral artery test is a very popular test that's discussed in assessments for upper cervical spine injuries and injuries to the vertebral artery. And my stance on it is I no longer do it. I don't think it's a very safe test. And I've got a slide on the vertebral artery test specifically in a moment. But the first thing you want to know is the patient experiencing dizziness or vertigo? And you want to clearly define the differences between those two because they are very different. Dizziness is an internal feeling of instability. So I go from sitting to standing and I feel like I'm going to fall over. Vertigo is a visual disturbance in the environment. The room will spin, tilt, tip, move more closely or further away from you. And that is characterized as vertigo. So I'll say that again. Dizziness is an internal feeling of instability. Vertigo is a visual change in the environment. The environment is either spinning, tipping, tilting, moving more closely or further away. And often the person in response to vertigo will close their eyes. And dizziness and vertigo is very complex, and we could have a whole discussion on those two, but you want to try and clearly define those. The next is diplopia, which is seeing two things, so seeing double vision. So when they try and focus on something, they're seeing 2 of it. The third is dysarthria, which is having trouble speaking. The fourth is dysphagia, which is having trouble swallowing. The fifth being drop attacks. Drop attacks are spontaneous loss of balance or falling on the ground. Now, these are the 5 things that we often look for in the vertebral artery test, along with these next 4 being ataxia, which is a gross change in the way that we move or walk. Nystagmus, which is a ticking of the eyes, or if these are the eyes resting in place, they're moving up and down or side to side. If they're feeling nausea or in particular facial numbness. So what I've done here is I take all the elements of the vertebral artery test and I try and question them about the test itself. And then I use elements to see whether or not they're experiencing symptoms that I can't ask them questions about. So for double vision, take a pen, have them focus on it, and just the tip of the pen, do they see 1 or 2, and hold it maybe 10 or 15 centimeters away from the face. Nystagmus, you want to look in the eyes and see whether you can see those eyes shaking, and then have them very simply track an object left to right and see whether the eyes tick more when they're moving to the left or to the right. Alternatively, you can put a piece of paper up at the corner of the eye, for those of you that can see me, and say, look through that piece of paper to the left or look through that piece of paper to the right. The reason that you use that cue is often people with nystagmus, when they focus on an image, visual fixation will take away from nystagmus. So if I ask them to focus on something, then moving to the left and to the right, I might not see that ticking or beating or twitching of the eye because the patient's focusing on it. So using that piece of paper is a good little trick. From there, you want to move into cardiovascular health. Why this is important is twofold. The person might already have an underlying cardiovascular condition, which I've found commonly, or because the concussion affects the autonomic nervous system, it can push people into states of higher blood pressure if they're already borderline hypertensive. So, and often, if they haven't been to see their general practitioner, and even if they go to see them for a head injury, I've had instances where blood pressure wasn't taken in those cases, and the person is suffering from high blood pressure, which is driving a lot of their symptom. So questions you want to ask: the classic chest, jaw, neck pain. You want to ask them whether they are experiencing amaurosis fugax, and what that is the curtains are drawn, but you're completely conscious. So it's as if you can't, everything goes black, but you can still walk around and perform all your activities of daily living. This is not fainting. Fainting is usually coming in from the sides and then you're losing consciousness temporarily. Amaurosis fugax just means everything goes black and you're sort of fully aware and cognizant and still sitting up. And why that's a red flag is it's often correlated to stenosis in the carotid artery, choking off blood flow to the brain temporarily, and is an immediate red flag that needs to be managed appropriately at the emergency department. Other symptoms: visual disturbances, so lights or blotches in the eyes are also symptoms of high blood pressure. Lifestyle choices, whether they are a smoker, have they had their cholesterol checked recently, are they overweight and of a substantial body mass index. And then lastly, but not leastly, measuring their blood pressure and measuring their resting heart rate. I think as massage therapists, we should be doing this for every single patient because we can catch early onset high blood pressure, especially if they're not going to their family physician. And often it is a byproduct, an autonomic byproduct of patients that have suffered a concussion where they may have already been borderline to begin with. So maybe they were like 140 systolic, and now the concussions push them into 160, 170 systolic, and they're starting to get not only post-concussive symptoms, but changes in blood pressure. In the other category, medication. So what medications are they taking? Is it a new medication? And that might be relating to some of the symptoms that they're feeling. And then sexual dysfunction, particularly in males, going back to the cardiovascular piece, erectile dysfunction is usually one of the first signs of cardiovascular disease. So if they're having erectile dysfunction, that may be something to think about with respect to the cardiovascular piece as well, paired with what the blood pressure is saying and the heart rate might require a referral back to the managing physician to get some further, testing done. With respect to taking a blood pressure, just some quick tips in blood pressure taking in general. Wait 5 minutes before you do it. So allow them to rest in either a supine or a seated position. Never take the first reading as the sole reading. Take an average of 3 readings, usually with 2 to 3 minutes in between. And the last 2 points are really key. Arm position and blood pressure can influence a lot of things. And the arm should be at the height of the heart. So if you're in supine, the arm and the heart are at the same level. But if you're sitting, the arm needs to be here because it can lead to false elevations in blood pressure if it's not at the same level as the heart. So keep it in a relaxed position on the desk. Also, don't ask the patient to breathe deeply or hold their breath. A lot of people, especially if they suffer from white coat syndrome or elevated blood pressure due to anxiety, they will breathe very deeply or hold their breath. When you do that, you're going to basically create a Valsalva maneuver, and that's going to increase your blood pressure as a result of that. So just say, be in a relaxed position, breathe normally throughout. Don't hold your breath. Don't take a big breath in. Don't change your breathing during the course of having your blood pressure taken. It's just a few quick tips to try and get the most accurate reading possible. Again, blood pressure has a lot of controversy behind it as well. Just because they have high blood pressure in one reading in your office, it doesn't mean that they have hypertension. However, if you find those readings, it'll be something that you'll certainly want to refer back to the physician regarding. So just my take again on vertebral artery test. What's happening if you're getting a true vertebral artery test? So vertebral artery test, again, is done. You're lying the patient in supine. You're taking their head into extension and rotation. They're keeping their eyes open and counting, let's say, backwards to ensure that they're cognizant. And you're looking for those 5 Ds and 3 Ns. So nausea, nystagmus, the things that we talked about on the earlier slide, dysphagia, dysarthria, dizziness, vertigo. If you're doing that in the vertebral artery position and the test is truly positive, what you're doing is you're cutting off blood supply to the brainstem. And that's creating a hypoxic environment, which is basically giving them an acute transient ischemic attack. And my view on this is that our goal as therapists is always to reduce harm first and have the patient's safety in mind. And so I don't think that this test, and there's a lot of controversy about its sensitivity or specificity in the research, I just don't think that we should be really doing this test. And that's my opinion based on patient safety. If they truly have a vertebral artery issue, this is the last position that we want to put them in because it can lead to quite a substantial medical emergency if, in fact, we do choke off an already stenotic artery. So just something to think about whether you're still using that in your current assessment methods. Lastly is just some discussion around when to refer back to the family doctor for imaging. And this has been taken from the Canadian C-spine rule out of University of Ottawa, I believe. And this is looking at when should you refer for X-ray following any type of accident. And so what warrants a radiograph or an X-ray? So greater than 65 years of age, a dangerous mechanism, so axial loading, falling on the top of your head, or motor vehicle accident, numbness in the extremities, especially if it's bilateral, and unable to rotate or move the neck, which is also known as rust sign. Rust sign is when a patient will present themselves like this with the palm of the hand on the chin, usually holding the head up. These are all considered to be red flags. No radiograph is needed or X-ray is needed when it's a simple motor vehicle accident, which again is in the hands of the doctors and the therapists. When they're sitting in the emergency department, when they're ambulating or walking following an injury, delayed onset of neck pain or no midline tenderness, so no pain on palpation of the cervical spine. This also brings question to MRIs and concussion. There's a recent study, and I failed to mention the author, but they looked at, it was hundreds of people that had suffered concussions and looked at the correlation to MRI. And essentially they found that there were no positive MRI findings on the hundreds of people that they did in the study. So outside of red flags on neurological exams, there isn't any evidence to suggest that getting an MRI would offer any further information that is otherwise not already unknown with a very thorough exam. In terms of any other symptoms, we can just look at, again, some of the standard things that we look at with all of our health history in our patients, which is frequency, location, the intensity of the symptoms, and any other associated symptoms. And then we've already touched on medications. Specific to concussion, you can use symptom scales. So probably there are a number of symptom scales, but probably the most popular symptom scale that you can use in an intake with your patients is a post-concussive symptom scale or some variable of it. And this is a 22-point symptom scale that's graded out of 6 with a maximum score of 132 or 114, because there are some questions related to sleep that don't always apply. And it should be known that in these symptom scales, people without a concussion will have some of the symptoms. So in the research, if we go to the next couple of slides, there are, so these are the symptoms on the left: headache, nausea, vomiting, balance problems, the list goes on. And as you can see by Lovell's research, if we go to the next slide, there's a section called borderline, which essentially means, these people, if they have, the raw scores of 6 to 12 or 10 to 20, may in fact still have symptoms without having suffered a concussion. So this is only, again, used as one part of the tool to really look at the patient as a whole. This is better served when you have a baseline of the patient. So when you have like what their numbers are before they had a concussion, and use this as part of your treatment plan. So if you had a baseline measurement for a patient, for example, and they had a concussion at day 1, and their baseline scores went back down to normal at day 3, you still wouldn't return them to play because, or school or activity in the context of like professional sports, etc. Mainly because the minimum period of time that anyone should be out is 7 days. So anyone that's being returned prior to 7 days will have not gone through a full and rigorous and thorough protocol. And so bear that in mind if people are wanting to return to activity inside of 7 days. That's not advisable. Going back to the top of the lecture, the reason that it's not advisable is because they're still in that acute metabolic cascade where the brain hasn't re-regulated its blood flow and re-regulated its neurophysiology. So just while I'm queuing up, if there are questions that people have, feel free to throw them in the chat. My website is available on the slide here, and my email as well. If you email me, I'll send you the copy of this presentation. And then there's some links again to my social. I also started a podcast because of Amanda and Mark, so my podcast link is there as well as some of my other social media. But if you just shoot me an email, I'm happy to send you a copy of the presentation. And I'll just see what's in the chat here if there's any questions, or if anyone wants to pipe up as well.
As well, Connor, if you send me those, I can also put them on the website, our Con Ed Institute website, for download.
Okay. So could what we call roid rage in high-level athletes be CTE? From James. I'm not sure that I would, James, go as far as to say that. There are a number of factors that can cause aggressiveness in athletes, steroids being one of them. But certainly you want to think about it in terms of psychiatrics and psychology, and just the more substantial the loss of memory, the depression, the anxiety, personality changes, you might want to start thinking about this, as well as whether they have a history of high-level athletics where they've hit their head or been hit a number of times. Robin, I don't know if you're familiar with wrestling, but could CTE be what contributed to personality changes around Chris Benoit and the Benoit family demise? I'm very loosely familiar with wrestling, but I think there is some discussion around that as well. I wouldn't be completely surprised. James, same question. Robin, can persistent post-concussive symptoms last in some form for many years? They can, and the more that individuals have the more concussions individuals have had, the more likelihood this can be the case. The other thing that to bear in mind is that sometimes all of the physical signs and symptoms of concussion have resolved, but what has not subsided is the person has developed an anxiety or depressive disorder in the context of the recovery, which is sort of just called a post-concussive anxiety disorder. And this is often the case when they've been really, really good with their physical rehab. And sometimes they've even done like things like cognitive behavioral therapy to manage their mood, but they haven't pursued things like medication. Sometimes that's what they need, and they need to see their family doctor or a psychologist or psychiatrist rather, for medication. So this is an important thing to recognize, where especially if they've had it for 6 or 7 months, they get caught up in things, and it's a very frustrating injury to go through and very, very scary. So that's an important thing to remember.
Hey, Conor, it's Amanda. We have a question here from Facebook that says, how can a massage therapist help a patient with concussions? What are things we can do as massage therapists and rehab?
Okay, good question. So first is full neurological exam. Like I said, I think ruling out red flags. The reason why this is so important, I think, this presentation, is it's being missed by, it's just being missed by people. So the recognition of red flags first. You can argue that with any concussion, you're going to have a whiplash injury. So whiplash injuries happen at substantially less force than a concussion will. So I believe whiplash injuries happen around 4 to 6 Gs, whereas, the research is still out on concussion. But you can assume that if somebody has a concussion, they've almost always had a whiplash injury, and the proprioception into the cervical spine is going to be altered as a result of that. So if you know nothing else and you are intimidated by the true neurological aspect of the injury, managing the tone of the tissue in the cervical spine, in particular the suboccipitals, because of rectus capitis minor has an attachment into the spinal dura and can influence a lot of ocular symptoms. You're going to want to focus on things like improving the tone of the suboccipitals, improving the tone of the scalenes and sternocleidomastoid, improving the mobility of the cervical spine, but also rehabbing it at the same time. If all you're doing is treating the cervical spine and you're making the cervical spine kind of like a loose noodle that's flopping around, and you don't give them some rehab, which can be as simple as cervical spine isometrics, so just going through flexion and extension, side bending and rotation in an isometric fashion. If you're not providing stability following kind of giving them new mobility, it will provide them temporary relief, but can often then perpetuate their symptoms down the road. This can also be found on just the difference between active and passive range of motion. If your patient has restricted active range of motion, but full passive range of motion, that tells you that their nervous system doesn't feel that they're strong enough to move into those ranges, and therefore they've got protective tone there. And that's going to perpetuate their symptoms. So understanding that is a very common presentation following concussion because of the whiplash portion. So ensuring that once you're relieving tone, you are giving them some exercise, and that can be as simple as isometrics. I hope that answers the question there. Andre, your thoughts on heading in soccer and concussions? Similar, Andre, to football, but, which is one of the reasons why they've taken heading out of a lot of soccer in the US, I know, and they're starting to look at heading in practice for the same reason, subconcussive blows over time, and what the evidence is suggesting. Kelly, can post-concussive syndrome lead to suboccipital neuropathy? And if so, just wondering how to distinguish between the two. Very good question. It can, well, I shouldn't say it can. It can be as a result of a hit to the head, in particular when someone falls backwards and hits the back of their head. the greater occipital nerve can get caught in the fascia of the splenius capitis and the upper trapezius. How that's usually presents is half of the head is an entire symptom. So they will say that they've got a very superficial sort of stabbing, lancing headache that starts high on the occiput just by the external occipital protuberance and creates half of a referral pattern all the way towards the just above the eye. This is quite significant. So like an 8 or a 9 out of 10, quite unrelenting. And when they palpate along the external occipital protuberance, they will get a lot of shooting along that pathway that I described there. Carolyn Dewell, what massage techniques do you find successful? I think I answered that. Joint mobilizations to the first rib is also a really, really good one just for reducing tone. Tamara, with regard to what is not a concussion, if concussion does not include increased pressure within the cranium, then what accounts for the decreased blood flow? How can you have extracellular inflammation outside the axon with an increase in pressure in the cranium?
Hey, Conor,
yeah.
We have time for one more question, but I realize there's lots of people who still have questions for you. So for anyone who still has questions for Conor, we can take this conversation to Facebook because we've got about 6 minutes left here. Okay. And then we're going to have to prepare for the next session. So again, with everybody that was here, if you want to stay for the next session, we're just going to put you in the waiting room while we set up, and then you'll be let back in at noon for Rob Haddo.
Okay, so after I answer Tamara's question, I'll go into the Facebook chat myself and address some of those questions.
Thank you, Conor.
So Tamara, with respect to your question, the decrease in blood flow is because of a lack of autoregulation. So the autoregulation is managed by the autonomic nervous system, so the balance of sympathetic versus parasympathetic. When you and that's mostly happening in an acute concussion phase. As you move more into extracellular inflammation outside of the axon, which happens more chronically in things like CTE, it becomes less about autoregulation. So in the more chronic states of injury, the brain does start to re-regulate itself, but because of this chronic change within the axon and the breakdown of some of the proteins in the area, which will cleave off inflammatory markers at the same time, that's where you start to accumulate inflammation both within the axon and outside of the axon space. I hope that answers your question as well. I will go into the Facebook chat if anyone didn't get their question answered. We are going to be discussing, I have a course coming up virtually at the end of September. If you're interested in that, you can see my website. Otherwise, good luck to all the other presenters today. Thank you, Mark and Amanda, for hosting and all the great things that you do for the field. And thank you for everyone that joined me. Really appreciate it.